do we have any state of art for ACS treatment, acute coronary syndrome treatment? I think we don't have a real state of art. We just have a kind of agreement based on clinical. Let's start with the classification of the acute coronary syndrome. This is the old classifications where we have three subtypes: unstable angina, ST elevation myocardial infarction, and non-ST elevation infarction. As you assume, as you can see here, that there are three main mechanisms describing how the consequences of this situation appear and how does it impact the clinical scenario for the patients. And this is the illustration showing that all stories about bad, real myocardial infarction where the artery is completely occluded, whether the second possible subtype is non-ST with the flow within the vessel, and the third one, so-called false myocardial infarction vessel. Okay, let's believe this about these three subtypes. Of course, these mechanisms and scenario is associated with the outcome of the patient, and we know very well that unstable angina has the best prognosis, the worst, this real ST elevation myocardial infarction. I don't know why it was here put, but what we know from the history, that the system should be prepared to fight with acute coronary syndrome problem. In my country, here in 2017, we had more than 140 centers located or distributed equally around the country. Right now, it looks even better. We have almost 170 centers. So the average distance between two centers is around 50-60 kilometers. So it means relatively easy access for regular citizen of my country. But all of this was based on this old truth that we have just two real myocardial infarction scenarios or endotype. The one was occlusive, fully occlusive, with the ST elevation on ECG or new left bundle branch block, with elevated cardiac enzymes. That was the STEMI, and end-STEMI with non-occlusive thrombus sufficient to cause tissue damage and mild myocardial necrosis, with ST depression or T inversion on ECG. And it looks like that. Right coronary artery occluded in a beginning of mid segment with typical ECG recordings. How we can tackle this, also using IVUS, and it was set in the first presentation. And then if you just find a good moment, these golden hours for this patient, you can really revert the changes in ECG. It means that the potential myocardial damage was very limited. For non-ST elevation, the problem is much more different. This is not only T inversion and ST depression, but technically this is just the same. Put the wire, use the balloon. If you think about thrombus, you can make a suction to improve the flow. But we have to remember that the process or processes which are present within the vessel wall, also on the surface of the vessel wall, are very complicated, very complex. And of course, the development of atherosclerosis plaque is different. There's many scenarios how can it go, and due to this situation, of course, the consequences for the patient and the best, let's say, the best protocol for interventionalists should differ for sure. And what I would like to show you, what I tried to tell you at the beginning of this state of the art, there are some facts, there are some already well-known situations where, in my opinion, were taken into the complex guidelines on acute coronary syndrome prepared by the experts of European Society of Cardiology in 2023. So this is the reason that I started like that. You can here appreciate a couple of potential situations which theoretically can be solved just by stent implantation. The question is whether this is the best option. The question which was given by Professor Dobrin, whether coronary stent is just old-fashioned device, I must say he's very close to the truth. This is what we have the best right now. But this is not the best what we the thing which we really need for our patient. If you look at these mechanisms, you can appreciate that not always the stent must be the best, because fissure, dissection, but also erosion. But we have also myocardial infarction in patients without obstructive problems in the coronary arteries. So we should take it into consideration. Today, there were a lot of words, many slides shown to you, how important is visualization of the coronary procedures. And of course, for acute coronary syndrome, OCT, optical coherence tomography is the best. This is for sure. Why? Because in majority of cases we see thrombi. So it means that only OCT is able to differentiate what is a soft plaque and thrombi. So this is unfortunately against OCT for these particular cases. When you are really interested in solving the problem or just searching for the reasons of acute coronary syndrome mechanism, OCT is much better a device. I don't want to go into the details, but you can appreciate here just a small thrombi, and here you can appreciate a red thrombus. This is white thrombus. This is I don't know. I don't want to go into the details. However, the most important is the fact. Is the fact that it really translates into the clinical. It should in the clinical decision-making process, and then we can really optimize very early, without repetition of the procedure, for example, 2 months later. I have my own ideas on the topic of previously presented, but maybe this is not the moment to discuss about that. Anyway, the visualization or intravascular visualization is a crucial moment just to decide what is the mechanism, how we can solve the consequences of this situation. Here you can appreciate the case with non-ST elevation myocardial infarction, where we see still flow. However, despite the let's say, narrowing, we have also a thrombus, which should be treated, of course, as well. But we have at least two additional mechanisms that should be taken into consideration, thinking about or talking about acute coronary syndrome. For example, coronary embolism. It occurs also in people without any earlier symptoms of acute coronary syndrome. But we have a couple of or many clinical situations regarding endothelial injury, anatomic predisposition, hypercoagulability in the patient, or just blood stasis or slow flow. So it also can cause acute myocardial infarction in our patients. So it means we should think much deeper and more wider than it was in the past. This is a spontaneous coronary artery dissection example showing how it can happen, mainly in women without any earlier findings or symptoms from the patients. And again, whether coronary stent is the best option for this particular mechanism. So we have a classification, we have some suggestions how we could solve, but sometimes it's much more wiser just to wait or just to be very delicate with the balloon, whether to stent from the beginning to the end of the artery. So I have already mentioned about Minoka. Minoka is a real problem. I would say that at least in 30% of patients sent to cath lab under the presentation of acute coronary syndrome. At the end, the final diagnosis is just a myocardial infarction without obstructions in coronary arteries. And of course, again, this intravascular visualization can help us to differentiate the patient, where there's really a problem which needs to be stented or just to treat the patient much more generally. As just a kind of reminder to you, we have to remember that in terms of acute coronary syndrome, we have to take into consideration the time from the beginning of process, which is expressed by the pain of patients mainly, to the consequences as a necrosis of the myocardium. We still remember about this the gold hour for fibrinolysis. For primary coronary stenting, I would say that we have a little bit bigger this range. One can say up to 4 hours. However, we see very clearly that the later we react, the worse outcome of the patient can be caused. So it's very important not to perform automatically just angiography and stenting, but before the stenting we should really find the mechanism, trying to understand and trying to optimize the procedure since the beginning. I don't want to go into the details of these guidelines of European Society of Cardiology from 2023. But what I would like to bring your attention, this is to the fact that the holistic approach to the patient is much more valid, important than we thought in the past. But I would also remind you that in terms of clinical representations, we have some additional situations which should be also understood as a presentation of acute coronary syndrome, because cardiac arrest, cardiogenic shock can be just a first manifestation of myocardial infarction. So keep it in your mind as well. What is also very important that this process of differentiation of acute coronary syndrome, this searching for subtypes of acute coronary syndrome is really worth to be done. Because why? Because we really know that for a real ST elevation, myocardial infarction, the decision-making process is relatively easy. Yes, for today we can say that coronary stenting with radial access, with the drug-eluting stent, gives you the best results. This is for sure. And we have to be very cautious. We have to look at and analyze the ECG recordings very carefully, just looking for any anomalies which can be associated with the atherothrombotic process on the atherosclerotic plaque. And then we can also use, after the angiography, intracoronary visualization, just to look for a proper mechanism. So the situation for NSTEMI is just different, because this is a much more heterogeneous group of potential reasons of myocardial infarction. So therefore, we know that only very high risk and high risk patients should be treated immediately, very similarly to ST elevation, acute coronary syndrome patients. The rest should be really cautiously diagnosed. We can really postpone a potential intervention. And also caution that this ECG recordings analysis is very crucial, should be done very carefully, and in any suspicious of problems, the coronary angio should be performed. Here you can appreciate not only coronary but also non-coronary and non-cardiac causes of MINOCA. So keep in your mind that there are so many situations which are unexpectedly can provoke a situation which gives us the scenario of real acute coronary syndrome patients, but the treatment is obviously different to a real full, I would say, acute coronary syndrome patient. Here you can appreciate a kind of practical algorithm how to guide intravascular imaging in acute coronary syndrome patients, just to differentiate the mechanism and just to, let's say, just to make our diagnosis most appropriate. So this is important. As I told you, these three mechanisms: erosion, rupture. Here you can appreciate also nodule. Today you heard about calcific nodules. We know that so-called ulcerative nodules with some thrombi on the surface are very pro-acute coronary syndrome situations. And of course, the spontaneous coronary artery dissection is also very important to be taken into consideration. By the way, I mentioned you about coronary thrombus. It was not shown here, but tell me, do you really need coronary stent when you open the vessel, which is not really atherostatically changed? No, you don't need it. So therefore, the mechanism of flow disperment is very, very important, as I already told you. This I like this slide very much, because here you can look at the strategy, how we should tackle the situations. Because in old good days, we believe that the more lesions we really treat, the more stent we, let's say, implant, the better situation and better outcome of the patient will be. Not at all. We know that we should really concentrate on a vessel, which really is a so-called culprit of the situation. However, of course, the question is in which way. But for multi-vessel disease, we should make a really complete revascularization. This is for sure. But for acute stage, the most important is the culprit lesion treatment. We know today how important is antiplatelet therapy, double antiplatelet therapy. I don't want to go into the details because of the time limitations. However, we have many scenarios, many possibilities. However, we should also remember that in acute coronary syndrome patients, the full antiplatelet treatment should last one year, so 12 months. And of course, you can appreciate here some varieties, how we should tackle, how we should take and choose the proper drugs. However, we know that significant part of the patient with acute coronary syndrome are very prone to hemorrhagic, to bleeding, let's say, problems. Therefore, also in these guidelines, you can find a table showing how we can make some changes regarding this potential bleeding problem in our patients. So we know also that at least 15 to 40%, depends on the population, patients which are treated with primary PCI have atrial fibrillation. So in atrial fibrillation, we have to take into consideration the anticoagulation, and then these 2 and 3 drug treatment should be really considered. So here also in these guidelines, there's very well described and based on many trials, proposal of how we should treat our patient. Here, this is the same. Let's keep it. And what is also at the beginning, I would like to ask you that what we see here, we can get much more in terms of late outcome of our patient when we cooperate with our patients. So, but patient, of course, should be informed and should be treated as a partner in this process, because the normalization of the blood pressure, the good treatment of high cholesterol level, the problem of diabetes, without cooperation between patient and physician, we'll never get good results. And of course, these cooperations should start before hospitalization. It should be continued during the hospitalization, and of course later on as well. Here you can appreciate the plan of well-known already in Europe, a Polish program on coordinated care to patients with after myocardial infarction. We call it COS-ZAVO, so COS infarction. So this is a relatively easy program. for 1 year with just 5 visits with meetings with a cardiologist, but with some consultations with dietetics, psychologists, with a good monitoring of modified risk factors, very short access to potential need for hospitalization. And what is most important, that this 1 year program really changes the outcome of the patients. The difference in terms of all-cause mortality is around 10% after 2 years of this, let's say, existence of this process. And just to complete my presentations, instead of saying about art of ACS treatment, I would say that the contemporary goals of ACS treatment is not just only the restoration of epicardial flow. This is not enough. We should think about restoration of microvascular flow. How we can do that? So this is the problem. If we are very fast, if we get this 1 or up to 4 hours, really the damage of microcirculation is not so big. So therefore we have to shorten the process to start the treatment. But of course, all of these details regarding good transportation of the patients, a good cath lab with a very experienced staff, all of these things, of course, well developed with all of the devices. But this is just all what we can do right now. The additional things are really depends on our knowledge and responsibility, because it shouldn't be, as I mentioned at the beginning, just why a balloon stand, go home. We have to think about the future of the patient. We have to treat the patient as the partner. So thank you very much for your attention.